Hello there, ladies and gentlemen. It is I, Vincent Kushkov, host of the Medi 101 podcast. And in case you didn't know, the Medi 101 podcast is a podcast about medicine and biomedicine. And if you're interested to join them, what complications and journeys there may be on the way. If you do know that, all brilliant stuff. But I just wanted to let you know that this style of content is longer than my other videos because I'm actually interviewing someone. There's a lot of questions being asked. Person's very willing to say a lot of things about their personal journey, which is incredible, and I hope you enjoy this video. Right. Hello and welcome to the Medi 101 podcast. I'm your host, Vincent Krishkov, and today we actually have a very special guest today, and we're going to be fulfilling my name of being a podcast, and we'll have a guest on our show, and I'd like to introduce to you very nicely and very honourably this wonderful dude who I met through pilgrimage in Lourdes called Dr Anthony Wijaya. Am I saying it right?
Yeah, absolutely. Thanks very much, Vincent, for the introduction. My name is Anthony. I am a surgical trainee working at Taunton. That's Musgrove Park Hospital. I am doing my final year of core surgical training, and I'm hopefully starting into specialty training very soon. So I graduated from Cardiff University. Shout out to anyone who goes to Cardiff in 2020. And I've been working as a doctor for 4.5 years now.
Wow, 4.5 years. And is that like, do you feel happy about your profession? Are you feeling all well at the moment?
Yeah, I think I've just finished a couple of on-call shifts, and I think generally, happy is a big term. I think I would say I'm quite satisfied with what I do. I'm very happy with how things are going in terms of my training, in terms of what I do at work. Obviously, there's no such thing as being perfect, as we will delve on later on. But yes, overall, quite positive about what's been going on so far.
All right, very well. Shall we get started with the main questions then? You ready for this?
Absolutely. Yeah, definitely.
All right, let's dive down a little bit into your background and find out a bit about yourself. So first off, shall we go on with the main question of what motivated you to pursue a career in medicine?
Yeah, so in order to answer that question, I'll have to tell you a little bit more about myself. So I am Indonesian born, so I moved to the UK when I was 15. So I did my A-levels in England and I went to med school. I have never actually thought about being a doctor until about, I think probably when I was 10 or 12, where my parents would just, keep asking, so what do you want to do? What do you want to do? And then initially, I have heard of the profession of being a doctor, and I just randomly said, oh, I want to be a doctor. But then little did I know, only after knowing a lot more about the profession, about what doctors do, about doing medicine, especially I ended up doing it in the UK, that I found out why. And to sum up everything, to cut the long story short, I figured out that medicine is a very broad career. This is the classical answer that everybody says, like you're helping people. Like there's no denying it. You are helping people, and you are applying your talents in your skills in a wide range of a variety of situations. And what I mean by that is, in medicine, you problem solve. You look at the given information that the patients give you, their symptoms, and then you work towards finding a diagnosis, and then formulating treatment plans and working with a whole host of teams as well. So it's problem solving, it's teamwork, it's an opportunity for me to use my communicated skills, and also to work with others via leadership or teaching-based methods as well. So a lot of the things that I find out that I really enjoy, so problem solving, technical skills, teamwork, leadership, teaching, it's all in one profession. And I feel that at the end of it, my Christian faith is also playing a big role in it. So I am a Catholic, and we know that Jesus is a healer. He performs a lot of miracles, and therefore that motivates me a lot when thinking about doing medicine.
Yeah, and you're kind of following through almost like his footsteps, and you're doing his teachings, and the fact that you get to do it whilst you're getting paid as well, it's all part of
Absolutely.
the experience and part of the fun, and it's really a good background and sort of a great environment up from what I understand the healthcare profession as a whole, although it is quite intense. And what would you say your journey was quite like?
My journey was quite complicated. Like if you compare it to the average person who gets into medical school, I would say it's a lot more long-winded and full of ups and downs. So I started obviously finishing my GCSE equivalent back at home, and then that's where I decided that yes, I want to do medicine. And when we figured out that in order to do medicine in the UK, you need to have at least A levels or an IB qualifications, and that my Indonesian high school equivalents would not be accepted to apply to medicine in the UK. I figured out that I have to do an A level course in order to get into medicine. And what I ended up doing was I looked, far left and right, back at home, looking for any schools, looking for any available A levels at home or abroad. And I came across my school that I ended up going to. So it's called EF International Academy. And at the time, they had a boarding school in Turkey, which is where you are. So long story short, I applied for a scholarship and fortunately was granted a what they call a founder scholarship to give it to 6 people worldwide to do A levels in England.
Wow.
And then I ended up doing 2 years of my A levels course in Turkey, and then applied to medicine. Now the story doesn't finish there. It actually was very difficult to get into medicine, as you know.
Yeah,
And
how
my
come?
journey was
Could
no
you? And
was
because I know the story, and but the viewers they don't know of the complications that you faced along the way, and everyone's worried about how to get into medicine, and they've all got these worries about the UCAT, the exams, and they, you know, I think by you telling your story, you're kind of giving us some comfort about getting into medicine into a high level university like Cardiff. So how were you able to do that?
I think, yeah. So obviously, it's difficult to explain without obviously everyone knowing the whole story. But effectively, what happened was I applied to 4 universities. I didn't get a great UCAT score, and I had one interview from my 4 choices of university. And then even after that interview, I didn't get in first time round. They said no, but then I ended up on their waiting list. But after achieving my grades, this is within the same academic year, I ended up getting into Cardiff, but having another step of hassle with delayed visas, with being late, blah blah, all of the stories which you know about. But I think one of the biggest things that I found out about how I cope with this was one is persevering and not giving up on your dreams, and knowing that no matter how hard it is, if you really want to do something, and you put your mind and heart and soul into it, then hopefully eventually there will be a way that opens up for you. And another part of that is my faith that has guided me along the way as well. So I know that I am not obviously forcing something. So whenever things don't go according to what I have planned, or I face a rejection from university, I know that it's not the time for me to just be upset and get drunk, or fall into different all sorts of things that young people do nowadays to get away from their difficult situation. But instead, by keeping my beliefs, by still doing my best in my studies, and by keeping the hope, and also praying that one day my hard work will be fulfilled, that keeps my spirits high until I finally get my offer, until I finally get into university, even though it was 3 weeks late, and becoming where I am today.
Wow, it's quite a fascinating journey. And you mentioned a lot about your faith guiding you. And as you know, a Christian, you said that it's got a big of an impact for you. But I'd say, is there a lot more to it that your faith adds when it comes to medicine? Like, were there any difficulties practicing your faith, both in your career and during your studies, for example?
I haven't noticed there was anything specific about difficulty practicing my faith. I think after all, like England is obviously very open to practicing everyone's faith. I think as a doctor, you have to be effectively not neutral, but you have to never portray or kind of like push down your faith or your beliefs on anyone else, which is obviously a very important part of being a doctor. But it does not stop you from practicing your faith and obviously living by its standards. And all throughout medical school, I've had no problems with that. There was a Catholic society at my university, and my church were very involved with the young people as well. So it was very easy to continue being around people of the same faith, practicing your faith, and also developing a further understanding of how my life as a doctor is relevant to my faith, because there's in most hospitals there are always a chaplaincy situation. So if there is a university chaplaincy, there is a hospital chaplain who are often multi-faith, and they're very open to the fact that patients who are unwell, who may be at the end of their lives, usually require some spiritual support on top of the physical support that they receive from the doctors and nurses. And I feel like I was a part of a volunteer at the university and the hospital chaplain in my hospital, and having that experience was really helpful to visit patients in terms of from their spiritual point of view, praying with them, and at the same time back then delivering Holy Communion. On top of then, before I became a doctor, and then thinking of it from the other side of helping them from their physical well-being and health.
So you're looking more at that other part of holistic care, where you also take care of individual from all the bases. And I think when you cover someone spiritually, it has had studies proven that praying will help someone recover quicker from some surgeries or something traumatic in their lives. And the fact that you get to do that as volunteering is quite incredible. Wow. But yeah.
Yes, indeed. Yeah. So I think it's there was a lot of studies that concludes that if it's all about hope, and it's all about how you perceive your current situation. If you obviously tell someone that, oh, you've got a terminal illness, and then say, for example, you have no hope, there's nothing else that we can do, a lot of people feel very sad about it, and especially if they don't have a certain value within themselves, they don't have a faith that thinks about, so what happens after all of this ends, what happens in the afterlife, was there any topic of eternal life and things. A lot of people feel very down, and a lot of people feel very demotivated, and once you lose that core values of what are you living by and what are you living for, things do get worse in terms of their medical prognostics. And being able to help people in their spiritual journey as well, to recognize their illness, and also to look beyond that, and also what they would like to do, and understanding that obviously there's a lot of different questions that, oh, why am I given this illness if God is good, and blah, 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 which is obviously probably a topic for a different talk, was very rewarding.
Mm-hmm. Yeah. I mean, to be able to volunteer as well and just put yourself out there, it really adds an experience. So when you get to meet with these people in person, because it's one thing to do all of these studies and understand what medicine is about through the internet, but when you actually go out there and you start helping people, and you're actually also putting your faith and practicing it as well, and teaching others about it, and it's all quite, I imagine, quite fascinating for you. So very well done for doing that. So yeah.
Oh, thank you, Vincent.
But you're currently a doctor at the moment, correct?
Yes. So it's to be pedantic. So I'm a trainee surgeon. So as to basically, when we have finished our surgical examinations, we get our title goes back to Mister, or obviously if you're a female, they'll go back to Miss. So yes, so I'm a doctor, but I am obviously a training surgeon as well, and yeah,
That puts you as a junior doctor at the moment, who's
Correct.
yeah, very well, very well. And how long would that training currently last? And what are you actually
So,
specializing in, so people can understand
mhm,
further on what you're actually doing?
yeah. So the term junior doctor is very broad. So it covers anybody who has finished medical school. We call them foundation doctors, all the way to when you finish your specialty training before you become a consultant. So they are called registrars and often associate specialists as well. So from when you finish your university until you become a consultant, usually the pathways involves at least, depending on what specialty you do, usually at least 7 to 10 years or more. And everyone is a junior doctor within that category. So the journeys would be you do 2 years of foundation training, so FY1 and FY2, where you rotate in different specialties and you do your foundation training. After you finish that, some people will carry on and do the basic training of their specialties. So you can either do core surgical training, or you can do internal medicine training, or you can do radiology training, or you can go into emergency medicine, go into anesthetics, you can go into what else? Psychology, reproductive and sexual health. So there's so many different branches. And those training usually last between 2 and 3 years. And following that, you then apply for your specialty-based training, where you normally focus on one specific subspecialty, where in some cases you do a lot of rotations within that specialty as well. So that's when you become a registrar. So that's training like vascular surgery, cardiothoracic surgery, general surgery, plastics, urology, neurosurgery, all of that. And obviously within medicine, you do one training of general medicine, and then you subspecialize a couple of years down the line. And once you've done all of this training, all of this, and that lasts for 5 years. So you've done 2 years of foundation training, 2 years of core specialty training, and then 5 years of higher specialty training. You then usually do a fellowship of some sort before you do your what they call your exit exams, and you can become a consultant. With the exception of emergency medicine and radiology, they only have 3 years of higher specialty training, and then they can become a consultant. But everyone is a junior doctor until you get that title of being a consultant.
Wow. And you always are guided by a consultant or a senior doctor, and you've always got someone who's kind of like almost checking up on you. And when they're naming someone to refer to, they always name the senior doctor, and then they go down to the junior doctors, from what I understand. So yeah, well, what is the training behind a surgeon really like for yourself?
Being very honest, the training is not easy. As with anything that comes in life that is valuable, they say it's never easy. So my training is quite different. So I did my medical school, and then I did my 2 years of foundation training. Back then, I wanted to do cardiothoracic surgery, so I wanted to do heart and lung surgery. But in the middle of my foundation degree, I had a lot of experience into that field of working as a junior doctor within the field. And back then I had a slight change of heart, and I wanted to look at a different part of surgery. So at that time, I wanted to explore general surgery and vascular surgery. Then after my 2 years of foundation training, I did a what everybody called F3 year, or a year where most of the junior doctors can choose to either do something else, either be a fellow in a different specialty if they want, do a locum, where you basically do very similar roles to what normally a senior house officer would do, but you're paid at a great rate. Or you can do traveling. You can go anywhere in the world. A lot of people go to Australia, some people go to New Zealand, and explore what you wanted to do. So I ended up doing a clinical fellow year in Bristol, in South Mead, where I actually discovered my true passion and liking for vascular surgery, something that I've not considered before throughout med school because I was focused on something else. And within that year, I learned how to perform operation within that specialty. I acted up as an on-call surgeon effectively overnight, so as a registrar. And I learned to work with so many different colleagues, do a lot of research within the area, publish and delivered an international oral presentation at a conference. So within that year, I felt like my training has changed a lot from the normal training routine. But because that year obviously was a non-training route, I ended up going into what they call a core surgical training last year and currently. So I'm at the moment towards the end of my second year, my final year of core surgical training. So that within those years, I have to partake in what they call an on-call rota. So that's where you do a long day shift between 8 a.m. and 8 p.m. or a night shift where you have to do 8 p.m. to 8 a.m. And in some smaller, what we call district general hospitals, you have to cover multiple specialties as well. So in the middle of the night, for example, in Taunton, we have to cover general surgery, vascular surgery, urology, and ENT, so head and neck. So any kind of emergencies, any kind of queries that comes along from those 4 different specialties goes to effectively one single person who is the on-call SHO, so senior house officer in general surgery. You'll obviously have a lot of senior doctors supervising you, but a lot of the times they'll be at home, and then you'll have to ask for their help appropriately. And if you have to do any kind of procedures, then they have to come in and support you as well.
Wow. I mean, there's quite a lot of roles then that I haven't even realised were involved between one person.
It's quite busy, and sometimes you're stretched in different ways where you have a couple of unwell patients. If you have to delegate your jobs, some of your jobs to your more junior doctors, so like the foundation trainees, or if you have to work within different specialties, say for example with the medical team, with the emergency doctors, and it's all a teamwork game. So you're never alone in your journey, but you do cover a lot of responsibilities when you're on call.
Wow, that's I've never realised how many sort of things you get to actually do as a person on call, that you have to basically juggle between all these different specialties. But do you get to know the team well? Do you get to get into the flow of it? Would you say it's manageable, or?
Yes, I think with anything that you practice, eventually things would fall into a flow, and then you would be able to kind of like perform more effectively under pressure as well. And you need to about, oh yeah, if this happens, it just basically goes here, or like in this scenario I would utilize this. So it is manageable because when you have a busy workload, usually you involve a lot more people. Usually you call for help, and then there will be different teams there. In terms of getting to know the different teams, there will be some teams that you get involved a lot more with. There are a lot more general surgery patients and sometimes urology patients compared to, say, vascular and ENT. It depends on where you're rotated as well. So during our training, we get to rotate every 6 months. And then, so within that 6 months, you'll spend a lot of time within the same specialty, where you get to know the rest of the team. You work together with the consultants who are the bosses, and then you rotate again. So, and the bit where you have to cover the different specialties are only when you're on call, and you are on call, say once every couple of weeks when you're within that particular rotation.
Yeah, I was gonna actually ask quite a lot about shifts, like which is your favorite type of shift or which is your least favorite shift. Like, do you get to, how many hours a week would you say you would work on average as a a registrar, I imagine you're called?
So I'm technically still what they call a senior house officer, so an SHO. Although what I worked last year was I was working as a registrar in vascular. So the timings is quite similar. So we work more than 40 hours a week, on average about 48 hours a week, which is what's highlighted in our contract. Sometimes, according to the rota, we may work a little bit more than that, so up to 50 to 56, but usually nothing above that. And that involves sometimes when you do a lot of on-calls, or when you do nights, or when you do weekend covers as well. We do weekend on-call during the day and weekend on-call during the nights occasionally. Whereas the registrars, it depends on where you are, but in some specialties, they do something that they call a 24-hour on-call. Or sometimes over the weekend, a 48-hour on-call, where you start at 8 o'clock, say, on a Monday morning, and then you finish on Tuesday at 8 o'clock again. Or if you're unlucky, you're working on a weekend, you start at 8 o'clock on the Saturday morning, and you finish after the ward round on the Monday morning about, after 10 o'clock or about midday. So we are obviously able to go home and to be off-site, and you are on call in a way that if people need your help, they will call you or they'll send referrals and through different platforms. But you are technically at work when you're in those times.
Yeah, because I can imagine the stresses of just going home and wanting to get into bed, putting on the Netflix, getting the ice cream out, and then all of a sudden, before bedtime, you just have a call saying, "Hey, we actually need you right now," and to come over.
Hey, come back, please. Yeah, exactly. Yeah. And that has happened before. Like, like every single possibility has happened before. When you're asleep in the middle of the night, I've been woken up before. When I was in the shower, that's happened before. When I was just about to eat my meal, that's happened before. So yes.
Wow. So you definitely don't like these sort of 48-hour on-call shifts at all. But
it actually depends. It varies a lot, and there are usually reasons why everybody is covering them. One, it's when you're on call over the weekend, it's a good training opportunity because usually there aren't any other lists going on, and it's just the emergency list. So effectively, if there's any operation that comes down your way, it will be you and the boss working. And a lot of the times, if it's a simpler procedure or ones that does not involve very high technical skills, your boss just basically says, just crack on and do it. I'll supervise you, blah, blah, blah. So you're effectively getting more training. You're not having to think about, I have to balance my time during the wards or doing a bit of clinics and also getting to theatre. But actually, over the weekend, it's all yours. Any kind of operating, you will be there. You'll be either the main surgeon or the assistant. And often on the weekends, you have to think as well, like as normal, layperson, you probably don't want to be in hospital. So all of these, operate based on things that are unfortunate for the general population. So they became unwell or they had an accident and therefore they come into hospital. So oftentimes we will have some weekends where there are no patients. So there are patients who, well, obviously there are patients within the hospital that we have and see, but say sometimes there are no new referrals, there are no new patients who are walking into hospital, which then means that you are free to have your own time to do some research, to cook, to sleep, to, partake on your daily activity.
Mm-hmm. Very well. And that's all pretty much, I'd say you're quite used to it by the sounds of it, and you've gone through it all. And how do you cope with all of that emotional stress, or how much of a burden is it on you, I'd say?
I think it's certainly when so obviously there's a difference. So when we do our SHO on calls, when we do our where I'm working now, we work 12-hour shifts. So we work, for example, from 8 o'clock till 8 o'clock, so either AM, PM, or PM to AM. But we do 4 of those days, or 3 of those days if it's in a weekend in a row. And sometimes a lot of these can be busier and more physically taxing on you because you have to run around, you have to see lots of people. If you have to go to theatre, you have to get changed, you have to rush into theatre, and once you finish your case, go back into the surgical assessment unit. You have to see the patient and make sure your juniors are happy and come back again. And you have to go to A&E sometimes. You have to go to sometimes a maternity unit if there are issues with them, with somebody who's pregnant with tummy pain. So it's a lot more taxing compared to sometimes when you do one single 24-hour on call, say, for example, as a specialist, because sometimes you will have emergencies, you will have sleepless nights, but a lot of other times you will have times where you finish your work, you get home at 8 or 9 p.m., you have your own time, and then sometimes you don't get called at all till the morning. So if you're very lucky, you don't get called. But if you are, then obviously it's having that ability to kind of like calm down and know that, yep, somebody needs my help, I need to be in the hospital, then just carry on. And then, like make sure you got the basics, like have some food, take some multivitamins, making sure that you're well hydrated, making sure that you're in the right zone to perform your duties, like taking care of yourselves before you obviously can take care of other people as well.
Yeah, it's kind of like that airplane situation where you have to put your own mask on first before you help others.
Absolutely.
Because there is a lot of errors that can happen during these sort of procedures. And do they happen quite often?
So obviously everybody's human. And then when we're describing errors in surgery specifically, we look at errors that are one never event, the things that should not happen at all. So things like you're operating on the wrong side of the limb, that's completely normal, or you're giving somebody treatment that they haven't consented to, or like usually these are like top big scandalous things that happen. So on one spectrum, these never events are what they say on the label. They are almost a never event, so they almost rarely happen. We're all at the end of the day human beings, and there will be small things that are they may be missed, or different things that are done not in a certain particular way. So the common things that happens in terms of errors would be things like, oh, you should have documented something, or you've forgotten to write something down, or you should have, say, for example, it's usually the simple things, like sometimes patients who come into hospital, they get stockings to prevent them from having blood clots, not in vascular surgery, but in generally in surgery. And then sometimes these small things, they are very small steps, but a lot of times when everyone's busy, these small steps gets forgotten, and and sometimes it takes a while for it to be done. But within surgery itself, I would say the occurrence of these are usually quite rare, because surgery are always a team game. You always have somebody who supervises you, or you're always supervising someone else. So a lot of the times, the aims that we are trying to achieve in surgery are achieved, or otherwise we wouldn't, we would think hard before we want to subject someone to this procedure, obviously. And oftentimes things go according to the plan.
Sorry for the pause, guys. We did have a bit of a technical issue with Zoom. I don't know why. It just likes to complain every now and then, so you can only live and learn about that. So we try to make good quality content. And yeah, so as a junior doctor, how well supported do you... Oh, wait, I think I already asked this question, did I? That you feel well supported?
Yeah, we feel, on average, you never kind of like work under no supervision at all. So like usually especially when you're doing something technical, when you're operating, there's always somebody supervising you, obviously up to a stage. When you're doing really simple procedures, and when you get through a lot of these procedures, you get to become competent and do things by yourself. But there is always somebody to ask questions to, even though they sounded like silly questions, even though they sounded like, oh, I'm asking this again. You can always escalate to a lot of people above you, because the term junior doctor also involves a lot of people until they become consultants.
Yeah, and I imagine there's also a lot of that learning process where you have to go back home and you have to look at the textbooks or look at some lectures. Is there still that element to it after you've passed your Foundation 1 and Foundation 2 training?
Actually, surprisingly, there is very little of that in terms of your day-to-day job. Your day-to-day job, you normally get a lot of feedback either on the spot. So if some consultants like to ask you different things when you're seeing people. So let's say if you've seen a patient with condition A, they will ask you, so Anthony, what would be the most common cause of condition A? And then you basically learn on the spot, to kind of like, if you've read it before, if you know about it, you obviously can answer it. And then the next question comes along, oh, what kind of surgical procedures might we do to treat condition A? Or like, why are we asking about this specific thing in relation to condition number A? And a lot of things that you learn is mostly for your professional membership exams. So, say for example, in surgery, we have to do the MRCS exam. So that would be the membership of the Royal College of Surgeons, which enables you to use the title Mr. or Miss, and have the suffix MRCS after your name. So in surgery, for example, you have to, within your training, spend some time to revise and sit those two parts of those examinations. And the same thing in medicine, in internal medicine, I mean, you will need to sit the equivalent of that. So for example, an MRCP, membership of the Royal College of Physicians, for example, and with radiology and emergency medicine, obviously the equivalent of that. So there is a lot of time spent at home to revise for exams, but not necessarily to revise on what you're doing on a daily basis. I think everybody, as part of their reflective learning, thinks about their feedback, and as part of that, you can look at different things, lectures and stuff, but it's not a mandatory part of a course, for example.
Very well. So there is that bit of training, and from what I've heard, you do have to still pay for those exams out of your pay grade and pay check.
Out of your own pockets, yes, absolutely. So for example, as a surgeon, we sit the membership with the Royal College of Surgeons, which consists of two parts. So the first part is a multiple choice question exam. So you still have to do that until the end of your career, unfortunately. So that is a 2-paper, I think it was, I can't remember how many hours in total it was, something like 4 to 6 hours in total on the same day. And you have to pay £600 for one sitting. And then the second part of the exam is a clinical exam where you have to go in a circuit rotation where they examine you about different things, about anatomy, about how you speak to patients, about how you deal with emergencies, about how you make a phone call to your bosses, how you examine patients, break bad news and things, where you have to usually go to a center for examination. So either you have to go to London or you have to go to Edinburgh or some other regional centers as well. And that exam costs £1,100 for one sitting.
Blimey,
so in total, just to do the exams is almost £2,000, minus obviously all of your travel expenses, hotel stays, revision guides, and everything else. And obviously, if you fail, you have to resit these exams, and you have up to 4 times resit for the first one, and 3 times resit for I think you have 6 times resit for the first part, and up to 4 times resit for the second part.
Wow, that is quite an intense sort of course. And from what I've heard, that the pass rate isn't even that good because they almost want you to fail. From what I've heard previously on some of these exams,
you can never say that they want you to fail, but because everybody needs to pass with a relatively high standard. Because it's all standard set. So you'll come across this term in university where a lot of things are standard set according to the performance of everybody in the same cohort. So, for example, the first part is usually the more tricky part because you need to nail down your science properly and know the basic science behind surgery. So the pass rate of this is usually, if it's raw marks, we're talking about 70% of all the questions. But usually, a lot of people unfortunately did not pass this. So the passing rate is somewhere between 50 and 60%. This is talking about based on the previous years. So it's not uncommon to see people having to resit the first part of their exam. Whereas on the second part, the more clinical bit where you get to meet your examiner, you get to talk in person, you get to perform your examination and different things. A lot of people are a lot more comfortable doing that. And usually the pass rate is usually about 75% of attendees pass the second part.
Wow. And you're hopefully training, well, you're still in training from what I understand to do those exams?
I'm still in training to do my core surgical training, but I have fortunately passed both of these exams. I've passed them within a close timing of each other. So I sat the first part in September 2023. Fortunately passed first time round. And then when I figured out that I passed the first part, I was like, right, let's just do the second part on the next available sitting, which was February 2024. And fortunately, I passed them on my first attempt as well.
Wow. So we've got an absolute nerd over here who's able to pass through anything.
Yeah, in some area.
Yeah. But you do have to be quite
It's good
intelligent.
to be nerd, you know. It's good to be nerd.
Oh yeah, it absolutely is, especially in this profession. I mean, everyone's got to be at a very high standard, and no matter what, it already starts at A levels, and then even GCSEs, and it goes higher and higher and higher. But no, would you say the work is sort of progressive as well, where it's like you get to do a lot more complicated procedures and a lot more mentorship as soon as you go, wow. So are you currently mentoring people right now as a SHO, right?
Yes, that's correct. Yeah, so we're always encouraged to mentor and share our experiences, as that's how we initially progressed. You know, from the bottom, there's always somebody there helping you to, you know, show you the ropes and show you the different tricks of how to save time, how to perform procedures, and yes, absolutely. So at the moment, we don't have currently a specific mentoring scheme where you do like mentor a specific same person and follow them throughout the year. The consultants do have responsibilities for that. But when you're working either on call or operating, you're always supervising someone else. So there's always somebody more junior. So even the junior doctors, even well, we're all junior doctors, even the foundation doctors sometimes supervises the medical students. So they always have people to, you know, look after, share what you normally do, and also be responsible for everything that they perform as well. So say, for example, if one of my foundation doctors or medical students did something and then they forgot to check something, it is obviously my responsibility because they directly present that patient to me or make sure that the management plan that they form and the treatment that they have is already, you know, is top tip. Because otherwise, when the bosses come along, it's still my fault, even though obviously the foundation doctors or the medical student would see them first.
Wow. Because there is that responsibility, though, isn't there? Where would you say it's the same with you? So if you were to, let's say, do a little muck up at the surgery and like the supervising doctor, he was at the toilet. It's that. Is it the senior doctor's responsibility that?
So at the end of the day,
falls on?
with because when we say senior doctors, we're talking about consultants in general. So there's always, so their names is at the top of the paper that says, you know, who is the responsible clinician for this patient, and that's Mr. or Miss so and so. Obviously, whenever every single clinician have what we call a duty of candor. So what that means is a duty to be open and honest about your mistakes and do everything that you can to fix that mistake, and also explain to your patient as well. But say, for example, if we did something, you know, if I did a mistake in an operation, and then say we were doing a vascular operation and I made something bleed, that's a mistake, or that could be as part of just, you know, risk of the procedure. Then I would obviously do my best to reverse the situation. And then obviously failing that, my bosses would be able to help and support me in that term. And there's a lot of things that we can do to, you know, to fix things. Especially, so, you know, like vascular surgery being a very problem-solve based operation. So say if you have bleeding, you can stop the bleeding by tying a vessel off, or if the vessel's all lacerated because of a gunshot wound or a knife laceration or disease, you can a lot of times, say for example, take a new vessel, so based on veins or like a plastic grafts, and then you can actually reconstruct those to replace what's gone wrong or what part of the damage was. And failing that, you obviously you have different techniques to fix the issue as well. So obviously the whole team would then work together to fix the problem. But then in terms of responsibility, all the direct responsibilities are obviously under the senior doctor's name. Although if obviously you did something bad, then that would obviously flag up within your training as, you know, obviously you performed something. There's usually a big meeting afterwards where everybody obviously thinks about what could have done better, you know, what repercussions would this have, and at the end of the day, how we can improve patient care as a result of this mistake or this error. So it's never always about blame and shame culture within medicine, but it's a lot more about a mistake has happened. What can we do to fix this? What can we do to prevent this from happening again? What kind of educational points can we take and share with the future generation in order to avoid this and improve patient care?
Very nice, very nice. So there is that bit of structure in place. And speaking of structures, is it all right if we move on to the NHS as an employer?
Yeah, absolutely.
And in general, so at the moment, how would you feel about the current structure of the NHS at your current position?
So when you're asking about structure, are you talking about the structure of
So within,
the
I'd say
doctors who are
within the
working, or
teams and within the finances, would you say you're currently satisfied with the situation of the NHS?
so in terms of training, I would say that the way that if you're training as a doctor in the NHS, it's not perfect. It's actually, there are quite a lot of loopholes, which is why a lot of people are leaving the country. Say, for example, you've seen a lot of people left for Australia, they go to New Zealand or go to Singapore and different parts of the world to practice. At the moment, a couple of things that I am grateful for is that in comparison to a lot of the other healthcare systems in different countries where you have to work a lot more hours, for example, in America, in Singapore, you're expected to work almost 10 to 20 more hours compared to what we're already working now, albeit with, like, say, almost double salary, for example. There is the culture of, oh, the junior doctors have to round up and see all the patients by 6:30, and then the middle grade doctor will come and see them at 7:30 or whatever, and then the bosses will come in at 8 to do a final round, effectively to reduce errors and to prevent any kind of omissions in different management plans, because 3 people have had a look at it 3 times, kind of thing, you know. In the NHS, there is not that expectation to come in extra early to prepare for things, or like stay super late to do extra things, because there is that expectation of, if you're working within your capability, you're working effectively as well as part of the team, you should be able to finish your roles within the given time frame. Unfortunately, that's not always the case, and a lot of times, especially in a field like surgery, if you're dealing with a complicated operation, sometimes things will carry on outside of your work hours, and there is a recognized pattern to think about what we call exception reporting. So to let your employers know that, oh, you know, I had to stay at work for a couple of hours, and then I need to, you know, therefore, what can I get in return? Either it's extra payment, or once you have worked a couple of hours, you can take a day off in lieu, for example. So those systems are in place. But in terms of progression and training, it may not necessarily reflect the best system out there. For example, you as a middle grade doctor, say as in the registrar training, quite a lot of trainees have to spend a long time. So they have to spend 5 to 6 years of doing the training, in comparison to, well, this is on top of their 2 years of F1 and 2 years of F1, F2 and 2 years of SHO. So therefore, it almost takes you another 10 years after med school to become a consultant plus. Whereas in a different healthcare system, you know, Singapore, Australia, sometimes it's a lot shorter. You can almost take away a couple of years from those training years. And in terms of progression, I'm sure you've heard about the junior doctor strike in England. You've heard about that. There has been pay erosions.
And were you involved with these junior doctor strikes? They were to increase the pay rate, right? Because they weren't very satisfied.
Yes. So what happened was, in the last, say, 25 years, there hasn't been any pay adjustment in accordance to the inflation that's been taking place in the last 25 years. So in order to look at it in a practical example, if I look at my salary now, and look at my boss's salary 25 years ago or 20 years ago, when he or she is at my stage, the amount of money, the amount of clean pay that we get is almost very, very similar, like almost up to the £100. It's like, you know, like it's, and that's kind of shocking, because within the last 25 years, obviously there has been a lot of things that's been going on. So the BMA, which is the British Medical Association, who obviously represents junior doctors, have summarized these findings, and that there's a lot of pay erosions, and there's up to 35% of adjustments that were missed in the last 25 years. In terms of the strikes itself, I have taken part of some parts of the strikes, and generally the consultants or like the bosses who are within the hospital are very supportive of these industrial action, because they know that how hard it is being trained. And at that stage, that, say for example, the pay in comparison to the rest of the population makes medicine remains an attractive career. And at the moment, what happens with our cohort now, with the current batch of junior doctors, is that with the difficulty in rent, with housing prices, with everything that just keeps going up after the pandemic as well, and that you had to pay for your courses, you have to move around as much. And even then, on top of that, if you're not trained as much, then it obviously puts a lot of stress in the current trainees. And therefore, even the government and the BMA have recognized that medicine at the moment is not so much a very rewarding or an attractive career as it was once before. So we're hoping that there will be different steps that, together everybody, all the parties involved would be able to improve in the upcoming future, so that when you become a doctor, things are a bit better for all of us.
And I'd say there was also, from what I've read, there were quite a lot of people who, junior doctors especially, who had left the medical career. Are there any that you had known of who had decided this is too much for them and they'd want to perhaps pursue a different, either healthcare profession or different sort of career option, maybe even abroad?
Yes, yeah, I've heard of a couple. Well, not so much kind of like famous people, but like people who ended up doing something else and they become famous as a result of it, either as an influencer on YouTube, or people who started in tech companies or in drug companies, who end up making a lot more of a living, as in comparison to their peers after the number of years of graduation. I've also known a couple of friends, like people that I've known in person, who have decided that actually I would do something else, or like I would move elsewhere to do something else that I can do with my time and talents. So I do know a couple of people who are doing that.
And have you faced those difficulties yourself? Has there ever been a point where in your career you may wanted to quit because of the financial stress or because of the stress of your career, perhaps? How close have you come to quitting?
So, being very honest, and I'm very fortunate that at this stage, I have not come across the thought of that I wanted to quit or I wanted to do something else. When I was in A-levels, I quite enjoy a different variety of things. So my fourth topic in AS level was law. So I was thinking that, I enjoy public speaking. I enjoy, researching and problem solving as well. So I once was offered by the University of Leicester to take law, for example, before I went to medicine. And I really enjoyed computer science as a hobby as well. I enjoy all things computing. And at some point I thought that, whether I wanted to do all of the, either one of these three careers. But once I started to medicine, fortunately, and by the grace of God as well, I found that I was quite happy throughout my journey in medical school. I was happy throughout my training. I, even though the work is hard, the hours are long, and sometimes you don't get enough satisfaction as a result of either just being overworked, or you have different things that a lot of people at your stage would be able to do. Say, for example, go on holiday whenever they want, because they don't have these commitments of being on call. But at the moment, I'm quite positive and feeling optimistic about the future, that, you're persevering, you're doing your best. And, as long as you're trying with the right motive and motivation to be in the future, you should never be discouraged based on what happens around you, especially things that you can't control.
That's very important. And you did mention about, you're trying to improve upon the future, so it's easier for junior doctors next year to perhaps go through that training easier without financial stress or without some of the stress of training. So how do you see the future healthcare system in the UK, and what role do you have in that evolution? How would you help those people? How do you see yourself helping these people move forward into their career?
So ever since I was in university, I've always liked the idea of teaching and the idea of education. So when I was in first year of uni, I started tutoring for A-level and GCSE students. And there was once where I had quite a lot of students that my weekends and my evenings were basically just, all right, I'm going to help you with your A-level exams and all this. And then throughout the year, I ended up partaking in different societies in doing a lot of teaching and getting involved in an international Zoom teaching by the end of my medical school career. So what I'm interested to see is that one, there will be a much more reformed career progression and training. So you try and identify the different problems that happen. You try and identify from both ends, from the consultants end, what are you thinking are the key outcomes that the next part of the future consultants would be able to do, and versus what the junior doctors want, what we want to do in our career, what kind of difficulties do we face, and I'm hoping to be involved in that part of things in towards education, and in terms of pay. We're hoping that obviously, things are progressing in terms of the discussions with the government, with the BMA, and that eventually we would reach a time where a lot of the hard works and dedications of all the doctors, not either junior or senior, would be seen in society. Because at the end of the day, the whole point of the NHS was to provide a free-for-all healthcare at the point of need. So we're all living in a very precious situation where we are able to get healthcare. Nobody is abandoned. You can access healthcare whether you have money or not. Whereas in some other third world or developing country, you would see situations where people are denied access because they don't have enough money to sustain themselves, or people who really need a treatment but they can't afford it. So and I think being in a space where living in a country where that healthcare system exists also gives you a lot of reassurance as well, that you are doing the best for your patients. You're doing it in their best interest. You're not requesting investigations, performing treatments just to get more money, because that's the other part of things, whether you rely on your conscience as a doctor, whether you are able to not worry about thinking that, oh, I need more money. Therefore, if I do more of these cases, will I need to do this. Whereas if you work in the NHS, you retain that whole value of living in your conscience, that you're doing your best to your patients and not for your own benefits.
That's very nice. Is it all right if we quickly move on to the personal and more faith-related questions?
Yeah, absolutely. And the more interesting side of questions.
Yeah, because it is quite interesting to talk about these sort of topics and the main issues at hand in terms of the NHS, but it is a really helpful system when you think about it. I mean, it's been set up, what 60 years ago or 80 years? No, it was 80 years ago.
Almost, it was set up in 1940, so we're almost heading towards 80 years. So, yeah.
So it's quite interesting. But as a junior doctor who will be becoming a senior doctor, how would you say it is in terms of availability to start a family or to start and looking towards a better personal life? Do you feel like you still have that opportunity to have the personal life, or no?
So it obviously depends on what your goals are and what you're looking at the moment. Being 2024, there's a lot of change and movement towards people are getting married at a later age. People are not getting married at all. It's very difficult to say. But my experience was that because we as junior doctors move around so much, it's very difficult to stay in one place and to settle down. I think that's undeniably a difficult situation, especially if you're not from a particular area of the UK. Say, for example, I'm an international student. I was an international student. I'm from Indonesia. So I don't have a base in the UK where I call home. for example. Even though I've lived in Cardiff for 7 years, I've lived in Taunton for 2, and I've known like a lot of other cities. So, which means that because you're always mobile, you're always in a new situation, meeting new people. But even before you can build something meaningful, you have to move again. So therefore, for some people who dislikes the idea of having long distance relationships or having to move around every year or every 2 years, it might be difficult. And that follows in terms of when or where would like to buy your property as well. Because imagine you're placed in Torquay for a year and you decide, okay, I'm going to put down a deposit for a house. And then next year you've moved to, I don't know, Northern Ireland, or you moved to Scotland. Like, what are you going to do with your place in Torquay? Are you just going to keep paying the mortgage, or are you going to sort out somebody to rent it? But then obviously that comes with a lot of pressure in terms of you need somebody else nearby to be able to look after it. You need to come back if there's problems, and on top of paying your own rent in your new place as well. So I think the structure of the career progression and the fact that you have to move around a lot makes it difficult for junior doctors, in my opinion, to be able to settle down and to get married and to say buy a house and continue their what everybody says is a personal life versus a working life situation. Mm-hmm. But I might be wrong. There are a lot of people who at that stage, are able to make things work. It doesn't always, there's never an always, so there's never a definite in every situation. And it also depends on the career type that you want as well. For example, if you want to be in one place, you can be a GP. You'll be in one place. You can apply to emergency medicine training, which you'll be in one emergency department. Or if you can do a different branch of medicine that does not require you to move around as much. So if you do something like surgery, you are probably going to move around a lot, which is one of the drawbacks.
But you do have to move around a lot, and do you pick these locations, or is that just...
So you obviously think about these locations, and when in every stage, so foundation training, core surgical training, higher specialty training, and consultancy, you apply, except consultancy, you apply through a national training scheme. So they identify all the training posts from Scotland till, I don't know what's the bottom end, probably in the southwest, it'll be like Truro or somewhere. You identify where you want to be, you rank these locations, and based on your portfolio, your interviews, and your scores, you will be allocated where you will rank, based on where you will rank and your achievements. So it's not always clear cut where you'll end up will be. And especially if you think about if you have if you're married, then if you're married to a doctor as well, then obviously he or she will have to think about applying to the same place as you are without a guarantee that both of you will end up in the same place. And that's the difficulty.
Very well. And just to wrap it up a little, I've got 2 more questions, and then I think we'll have to call it over because I've wasted enough of your time already. And with this interview can go on and on and on. I'm finding this quite interesting. Like, I can ask you a million questions, but there's 2 more questions left. And if there was anything you wanted to say to yourself 10 years ago, what would it be? That's the first question. And the second question is, what advice would you give to a viewer who's interested in a medical career?
Those are very, very interesting questions. Something that I would say to myself 10 years ago, I would say these 3 things.
Don't pick medicine.
Well, no. That's actually not in one of them. The first one is don't be afraid. It's almost something along the lines that it's going to be fine. Like, don't be afraid. Live your life to the fullest. Not that I didn't live my life to the fullest, but literally spend your time, explore what you liked. Go take those opportunities when you can, because when you obviously are in a working situation, your time is a lot more limited, and the amount of the type of people that you meet is a lot less restricted in comparison to when you were in A levels or med school. So that, and also stop trying to say yes to everything, which probably is an important thing as well. As a prospective doctor, as a medical student, you will get a lot of opportunities to do different things left and right. There will be lots of research projects available, opportunities to join a sport club, opportunities to join a different clubs. So I think if I would advise my younger self, I would have said that look at it properly and think about what you really want out of it. And instead of doing 50 different things, pick 3 or 4 that you really, really like, and then enjoy your time within it. And finally, to close off, what I would say to someone who's considering medicine as a career is that you got to have the right expectations and motivation. If you're in it for the wrong reason, if you're in it for money, you'll soon get burned down. You will soon see a lot of your friends who are in business, finance, and a lot of other stuff that will give you a lot more quicker gains. You would feel like, I'm working my life off, but then I'm not getting to where I need to be. It's a long-term game. You are working to become a consultant, and your salary once you're up there, in comparison to a long list of other occupations, are actually quite good. But the journey there is quite difficult. It's not easy. It's not for the it's only for the strong-hearted, and it's important to build resilience. So find out the reasons why you really like it. If you're not really sure, go in, delve into the experience, go on some work experience, talk to as many people as you can think of. Talk to the people who are in medical school, who are doing the training. How do you feel ever since you were in A-levels? Has your interest changed? Talk to people who are in their FY1 years. How do you feel ever since you graduated from medical school? Talk to people who are in the middle of their training. How has your life changed? And then at the end, obviously, talk to the people who are right at the top, the consultants, and to see what they think about it as well. And an own personal touch to this is having a good support method helps. Having a family who you can talk to, having close friends you can talk about, all of your career aspirations and the difficulties help. And at the end of the day, for me personally, having a faith is what really makes me where I am today. Being able to pray.
Sadly, Dr. Anthony Wijaya was not able to finish the last few sentences he wanted to, and the Zoom call had ended suddenly. And I just wanted to say, guys, I hope you enjoyed this podcast. This is my first ever sort of interview question. I mean, if you can have some critical feedback, or if you found that episode really interesting and that you've learned something new that you typically wouldn't by doing some research on the internet or watching another channel, then I'm really happy that you guys are able to get that information. And thank you very much for watching. Really special shout out to Dr. Anthony Wijaya. I'll be showing his Instagram probably in the bio, depends if he wants to be plugged in or not. And so hopefully, that's it, guys. Thank you for watching the Medi 101 podcast. Benson Kushkov out.